Good afternoon and welcome to the fifth webinar in our series, Improving Patient Experience in Virginia Hospitals and Health Systems. My name is Abraham Segrist here with the Virginia Hospital and Healthcare Association, and glad to have so many of you with us this afternoon. Before we get started, I'll just review our standard housekeeping notes. The webinar is being recorded and will be available on our website later in the week. All participants are in a listen-only mode. In order to ask questions, you can do so by entering your questions in the comment or question box in the control panel. The slides are not available for download this morning in the handout section, but they will be available on our quality and safety website along with the recordings and the executive summary following the webinar later in the week. And at the end of the webinar, a brief survey will launch asking for your feedback on today's webinar. Today's agenda, we will be featuring Ms. Nancy Littlefield, the Executive Vice President and Chief Nursing Officer at Riverside Health System in Newport News, Virginia, where she will share their experience with patient experience before, during, and after COVID. And then our colleague, Carrie Brady, will lead us in a few polling and discussion questions before we conclude at 12:30. Just to remind you about the Virginia Hospital and Association and who we are in regards to vision and our mission. Through the power of collaboration, we seek to be the recognized driving force behind making Virginia the healthiest state in the nation. Listed on your screen are the member hospitals and health systems that make up the Hospital Association. So glad to have representatives from most of these organizations with us this morning. The goals for our 2020 Year of Patient Experience to identify and highlight and celebrate efforts underway in Virginia hospitals to improve the patient's experience of care, to continue to integrate patient experience efforts with broader quality and patient safety improvement efforts, to connect Virginia hospitals for shared learning, and of course to ultimately improve the patient's experience of care as well as our statewide performance on surveys such as HCAHPS. Today, we hope that you will hear from one health systems regarding their impact of COVID on their HCAHPS performance, to get insights into staff attitudes regarding patient engagement with friends and families, and then a review of some essential patient experience practices that really make a difference. So without further ado, it is my pleasure to introduce my colleague and friend Nancy Littlefield from the Riverside Health System based in Newport News, Virginia, and also the chair of our VHHA Patient and Family Experience Forum. Nancy, the floor is yours.
Thank you so much, Abraham, for this opportunity, and how I wish that I could do this in person. For the ability of feedback and looking in people's faces and just having a greater dialogue. But I'm grateful for the opportunity to share with you our experience. And you can go ahead to the next slide, Abraham. So just a little bit about Riverside Health System in case you're not familiar with our health system. We are in the eastern part of Virginia. We are made up of 5 acute care hospitals. One of those facilities is a large trauma center in Newport News. We have 4 smaller facilities that are community-based on the Eastern Shore, Tappahannock, in the Gloucester area, and in Williamsburg, which is a relatively newer hospital, about 5 years old. We do have 3 specialty hospitals, a psych rehab and LTAC that we're in a joint venture with Select. We have Lifelong Health as part of an important division of Riverside that has 9 nursing homes associated with it, home health and hospice. And then we have a large physician practice group with about 620 providers, 132 practices. So we represent a really good continuum of care and that is really important for us to keep track of our patient experience. So I thought it was really important to really both be transparent in our journey. And let me give a plug for the VHHA's Patient Experience Forum, which I'm fortunate to be a member of. If your hospital is not actively engaged in that forum, I really encourage you to do so. It's people like like you and I, that are trying to make sure we're making a difference in the time that we have with our patients, and that our patient experience outcomes reflects the mission that we have. It reflects who we are as individuals and collectively as a hospital. And as you can see from our 2016 through 2019 snapshot, we were not where we needed to be. I gave three survey dimensions: overall rate, likelihood to recommend, and responsiveness. In 2016, I would say we were mediocre. We did a good job in quality, but patients' feedback with us was not consistent, and not where we needed it to be. We showed an improvement in 2017. 2018, we were relatively flat. And then we kind of took our gloves off a little bit and said, what do we want to do? How do we want people to describe us? How do we want to know we're making a difference and reflect our mission? So as you can see, in 2019, we really kicked it up a notch with our leadership team and had some significant improvement. And we recognized that we weren't done, but we really had wired some very good practices that are on the next slide. You can go to Abraham. So our improvement, 4 to 5 percentage points in most of all of our dimensions across our 5 acute facilities, is we became much more transparent in our data, making sure that everybody was on board with where their outcomes were. And how their progress was. We did have a corporate focus, and we have Vicki Morgan, who's a great patient experience system lead, but the tendency was that it was her accountability and not the local facility's accountability. So we really drove our conversations to make sure that our leadership at all of our facilities and the team members knew that their outcomes related to patient experience were ones that they owned, and it reflects who they were as leaders. We started biweekly meetings related to customer service or related to patient experience. Comments became a great opportunity when staff were recognized or not to pick up the phone and call staff specifically who were mentioned in a compliment to say thank you. I just just reading our feedback and received Mr. Jones said that you were just a great nurse in the middle of the night, and thank you so much for that. To make that experience real, and their feedback real to us, and not just data that was collected 6 weeks ago, and finally at 6 weeks after discharge we received feedback. We do use NRC as a vendor, and they provide a avenue to get real-time feedback for those patients that are hospitalized that don't meet CMS criteria for HCAHPS, and that we usually get that within a week after their discharge, and that provides us some real opportunity to re-grease the wheels and refocus, and again give staff genuine feedback about the great job they're doing or if there's an opportunity. Our mission at Riverside Health System is to care for others as we care for those we love, and aligning the outcomes of where we are in that improvement effort to that mission provided that sense of purpose that we needed to help be a catalyst. We did transition some people to a different seat on the bus, or transition some out of the organization when we couldn't get the connection between their work and what we were trying to drive as an outcome. And we did not have fear to do that. It was the right thing to do in order to move forward. We looked at a very detailed level of our staffing and making sure we were staffing to volume and not just budget, and a big focus to remove any and all agency who might not be fully invested within the mission of Riverside Health System. And then we kind of stepped back and picked three areas of focus. Probably the biggest is the relationship that our team could have with a patient and the family. Who is that patient? It is not just a person in a bed that doesn't have any history. Are they a veteran? Do they have grandchildren? Do they like to fly fish in Colorado? How do we personalize who they were and who they are to us, so it's not just task-based care where we're trying to accomplish the diagnostics and the implementation of a plan of care to get them to a discharge date. And we spend a great deal of time on that, but we really encourage stop chasing the latest strategy, which in this space there is a great deal of. You can advance the slide, Abraham. So guess what? We ended the year really strong and with a lot of improvement, and then came COVID-19, and you could hear kind of a gasp across the organization of what is going on. We had spent so much time and effort improving year over year, and our first 2 quarters really showed some decline, and that we were really missing the gate. We reviewed on the next slide, Abraham, some of our patient comments as we tried to dig down deep into this. And maybe you had similar comments in your health system. These are direct quotes from our feedback. Because of COVID-19, my wife was not allowed in. The doctor only called once and did not communicate anything to her. Everyone was really nice, but I'm deaf and had some problems understanding sometimes through a mask. Not having family visits during the virus scare was uncomfortable. Responding to my call bell took longer than last time I was in the hospital. Communication was difficult, and my wife couldn't be near me. Food was cold, served on paper plates, and I kept having to remind the staff about noise not letting me rest. You can go to the next one. So these were a very different theme of comments than we had typically seen all throughout 19, and they helped us focus on a couple things. Most hospitals self-reported were reporting a halo effect from healthcare heroes taking care of COVID patients, which we were within this area, and we were not. I think all of our CNOs, and myself included, had this pit in our stomach when we were hearing from both NRC and Press Ganey and some of my friends in hospitals that they had never had such high patient experience scores because of the phenomenal emotional connection people had with the healthcare teams who were taking care of our communities, and we were not there, as you can see from our survey. We were keeping people safe. We were very, very focused on appropriate PPE, making sure that we were ahead of whatever the expected viral impact would be with beds, etc. But we had lost that connection with our patient that was so important to us and to our improvement. Our focus of improvement in patient experience, where it was relationship based, really changed. It was much more safety focused and strict isolation, strict PPE, covering up all aspects of the face, and we found that we did not respond as quickly as we probably could have during that. Our connection, as I said, with our patients changed. In our improvement efforts through 2019, we really took a holistic approach with our patients about, again, who they are and who they were and who we are to care for them, and our nurses and their qualifications. And also took a great deal of pride in getting to know who their family was, and talking to the patient about who was important to them within their family. So our connection changed very drastically in that first half of 2020. As you heard from the comments, our leadership rounding that would have prior picked up complaints regarding communication or complaints about food or being cold or it changed, and our leaders were rounding more for checking for PPE, etc., but missing that how do I help the patient be as comfortable and as safe as possible, yet still having that emotional connection. And then, like many of you, we had visitation restrictions that were very, very strict, and that caused a great deal of concern, as I know it did within your organization. You can go to the next slide, Abraham. So how are we doing today? This is a snapshot of March, April, and May. So the end of March, we had a kind of a big huddle, the CNOs and myself and the patient experience reps with Vicki, to really talk about what strategies do we need to change immediately in order to get back on track. So we have been able to show some improvement as, and now some June surveys will start to come in and real-time feedback. We're showing some definite improvements to get us back on track, which is great. We're still struggling a little bit with responsiveness. Some of the feedback is related to the time it takes to get the PPE equipment on and that type of thing, but that is something that we're continuing to work on. So some of the lessons learned through this is basically not to panic. Patient experience, like your organization, is extremely important to us. And what our patients say about us reflects who we are, and both individually and as a health system. And we had to take a step back and take a breath to have confidence that our previous ability to improve throughout 2019, year over year, but really solidly in 2019, should give us some confidence that we were on the right track before COVID and its storm kind of came in. So let's go back to the basic. We felt that we needed to react quickly and try to find a new normal in the world of both PPE, anxiety related to the virus, visitation limitations. We needed to get our leaders back and making sure that they were rounding as they did. And our rounding of our leadership really includes the tone of the unit. Are any call bells going off at all? If we're rounding effectively, we should not hear call bells. If we're getting our team members to do that hourly rounding, what is the atmosphere within the unit? Is our team members making eye contact with each other? And how as leaders can we help to make sure that they have the tools that they need to do the job that they were hired to do? We found we had sporadic communication strategies to connect with loved ones. It was based really on how good the nurse was to help coordinated it, and we really tried to hardwire across our facilities set time for both physicians to talk to families and our team members to also connect with their loved ones. We are exploring actually right now through our Epic system the ability to send text messages like things are doing great, they're sleeping soundly. That can also add another layer of communication to a designated loved one, but we found that especially with the separation of loved ones to a patient, that we really needed to step up that strategy. To take in account the PPE and the inability to see a smile and to see an expression, which we had based on as such an important part of our improvement strategy. How do we go a step further and narrate all of our care provided? We're increasing the discussion into a patient, not just assuming they understand. Really paying a lot of attention to eye contact and almost trying to exaggerate smiling of an eye related to our expression, awareness of our own body language with the patient, and then a reminder to all of us to be resilient, to not be discouraged, to be resilient in this change, that we can handle it, as long as our focus is on the right thing, which is our patients and their family, and our eyes are on the target that we're trying to accomplish. An important part of all of this, as I've tried to share, was our ability to connect with our families. And when visitation became restricted, and then it eased up a little bit, a lot of our surrounding health systems opened up visitation a little bit before we did. We had a 2-week lag for a couple different reasons. And this letter I received to me, and it was from a wonderful nurse. And I am an older ICU nurse, and when I was an ICU nurse, you could visit 2 hours a day. You had to be family. There were such limitations, and we kind of got used to that. And then, thank goodness, times changed, and we opened up to open visitation hours. Well, then COVID comes, and we restrict our hours, and it really caused a lot of work with our team members from a communication standpoint. But when it was also so stressful on the unit side, it was probably good that you didn't also have 100 different family members that you were also worried about. But I received this from a team member that helped kind of put things in place for the importance of our visitation, important part of our relationship with our patients. And what she wrote to me, many of us would like to chime in and give our support as well for using the current, visitor limitation as an opportunity to reinstitute reasonable visitation. She expressed that, she understands the CMS guidelines and the why we had to do it. But so many of us hope that we will take this as an opportunity to reset things, because of the current restful environment is so much more therapeutic for the patients, including for many who say they feel obligated to receive visitors when they show up, and who voice relief at being able to just rest and not have so much well-meaning company. And thanks for listening. And what this email said to me was, we've got some advocacy for making sure that patients have what they need related to visitation, and that we needed to do it the right way. And I was really, really proud to get this, because as that old ICU nurse, sometimes it's easier not to have visitors. And did we need to do anything as an organization to make sure that we're instituting visitation in the right way? And having talked to this nurse that helped submit it to me, she just said, we really have adopted holistic care that includes loved ones, and our ability to connect with the patient as well as who cares for them is ever so important. And so that was an important part of our conversations and our discussions. And you can go one more slide. One more, Abraham. There you go. Some of our ongoing work, I just wanted to give a snapshot of this. We, as well as trying to adapt to COVID and the impact that of change that we had to do and all of us had to do related to that, we also want to stay ahead. And this is just a snapshot that we will be using kind of going forward, and really breaking down our patient experience based upon gender and age and race, and looking at our healthcare disparity, as well as our patient experience through the lens that I believe will help us as we work through challenges with healthcare disparity and some of the things that all of our communities are facing. One more. So the ongoing focus of our work, and I will help update Abraham on where we're going as we continue to try to improve, it is the importance of connection. Connection with each other, connection is part of even the VHHA family in our joint effort across Virginia to improve patient experience. How important it is that we connect in the right way to our patients and their families, to achieve the patient experience outcomes through an HCAP survey that reflect who we are and our mission. Our family advisory groups through COVID were put on hold. There were face-to-face meetings. If they're important to us, we need to reinstitute them through a Zoom process, and also make sure that they are representing the demographics of our community. So we'll continue to look at that. We really, through the work of our diversity committee, we want to look at diversity and inclusion as it relates to patient experience. And that will be some ongoing work that we have. And then looking continually at high reliability. We do not want to be an organization that picks a quick strategy and try something for a couple weeks and then moves on to something else. What is sustainable, whether Nancy's here or somebody else is in my chair, because of the processes that we have hardwired that are important to our patients, and they are not related to who might be on for the day or who might be leading these efforts. So we're we're not done yet. We share the challenges with you, and I would be happy to take any questions at this time, either through chat box or I guess audio, Abraham.
Yeah, what we'll do, Nancy, thank you for an excellent presentation showing the hills and the valleys of the journey at Riverside, and glad to see that things are sort of getting back up on track based on what you guys are doing pre-COVID. What I will ask the audience to do, if you have questions for Nancy, I'd ask that you enter them into the question box. I'm going to go and actually turn over to our colleague, Carrie, who will lead us through a couple of polling questions, and then we will look at any questions in the chat box and put those in front of our presenters.
Fabulous. Thank you, Abraham. So as we have seen with every presentation we've had so far in this series, these 4 foundations are really part of every example that we're hearing about. So as you're considering improvement, we want you to be always considering these 4 foundations. We have a few polling questions for you today. The first is, we wanted to ask how your staff attitudes toward visitation have been impacted by your experience during COVID. So we're hearing anecdotally that in some cases, staff are really missing that connection with family and realizing it's challenging to not have people there. So we wanted to see just what that experience is like in your organization. So if you just take a second and fill this out, then we'll get a snapshot of everyone who's on the call. One thing that we want to encourage every organization to do is take advantage of the fact that we are in a new environment with this pandemic. So no one is an expert, and it is an opportunity, whether it's with your visitation policies or really any other approach that you're taking, to take a fresh look at it, to see what's working and what's not, and to build stronger as you move forward and enhance what's happening. So of course, there's going to be some adjusting for different factors as you go along. But if you think of this as an opportunity to really change things and update them, then it can be very powerful. So, okay, we have a few people saying that that's interesting. So almost 80% of you are saying staff would prefer more restricted visitation permanently. Okay, and then a few on the other side. So that's really important to know, because it's one way for you to keep listening to your staff and saying you are allowed to make those reasonable restrictions, as the person that Nancy quoted so eloquently pointed out. Let's do something reasonable here. Yes, we're not going to go back to the old system where it's 2 hours a day and only a couple people, but I'm going to give you a quick example while we open the next polling question. So Abraham, if you can open the next one. We wanted to ask you about leader rounding, because we know that's really a very important practice and how the pandemic has affected. We're going to ask you about rounding on patients as well as rounding on staff. But this first question is rounding on patients. And while you're answering this, I want to give you an example from a hospital. This is a pre-pandemic example, and it's not a Virginia hospital. But there was a hospital that I had occasion to work with who implemented a really interesting practice in their labor and delivery. And what they did was they asked in advance, when they had, the meeting in advance with patients, to say, who do you want to be visitors during this time? And if they weren't on the list, they didn't get to visit. And so basically what the hospital reported was that the moms were so grateful to be able to say, look, I only want, this person here during these couple of days that I'm in the hospital, because then they could say, oh no, the hospital, they would end up saying that the hospital had made us say or whatever, but the hospital got to be in that gatekeeper role, and it actually made the patients much happier. So think about how that might play into it, giving patients choices, because you do want, of course, and need under the law to make them accessible to the people that they want to have seen. But how can you partner with your patients to find out? Okay, so we see here again, 83% of you are saying leaders are rounding less frequently on patients than before the pandemic. So that's important to know as well, because if the leaders are not getting that feedback from patients during rounding, then you want to think about how else you're going to get that feedback from patients. So Abraham, again, if you want to open up the next one in the interest of time, I'll give an example of how you can do that. Some organizations, I know it's non-traditional, have taken to social media to get feedback from their patients. And because no one is an expert in this, and this is all new, getting feedback from your patients in non-traditional ways makes sense right now. You're not obviously going to ask them about safety issues like, how do you feel about us wearing PPE, because you have them, but taking feedback, for example, from one of those quotes that Nancy provided about your patient who is deaf and how challenging that was for her. I know there are some organizations now using PPE that has a clear panel so you can still see somebody's lips, so people can read lips. So there's lots of ways to adapt, but you want to find ways of listening to your patients. So now, as I said, we were asking about patients and staff. Curious to see how often leaders are rounding on staff. It's really important. Okay, so the differential here between patients and staff is interesting. Half of you, roughly, are saying leaders are rounding more frequently than before the pandemic on staff. One amazing thing that has happened as a result of the pandemic is I think that in most organizations, leadership and staff are communicating perhaps more effectively or certainly more frequently than they did before, because organizations realize you need to be engaging your staff frontline all the time in a very meaningful way as you're coping with a crisis. So what you want to do, Abraham, if you want to go to the last slide, what you want to do is consider as you're moving forward, how do you preserve the great ways that you have of listening to your staff? If you're rounding more frequently and that's working for you, the other ways that you're getting feedback, you want to build on that and keep that communication going, those lines of communication open. Look for additional ways that you can connect with your community and get some guidance, even if it is non-traditional, because especially now with the concerns about in-person meetings, so look for other ways that you reach out. Maybe you survey the community about some things, or like I said, even some social media polling or engagement through there, or some phone interviews. Think about ways that you can connect with your community, because right now they're probably very willing to speak with you. And they recognize that there are these limitations on the traditional ways we've done things, because even though sometimes we like the traditional ways, there's lots of opportunities for improvement when we take a fresh look, and we're all taking a fresh look right now. So Abraham, I'll turn it over to you to discuss the upcoming webinars and see if there are any questions. Thanks, everybody, for all of the work that you do. You are doing amazing work every day, and your communities are lucky to have you.
Thank you very much, both Nancy and Carrie. I'm looking at the question box, and I don't see that any questions were submitted. So I think it means that everything you shared was right on point and very clear. As we mentioned at the beginning of the webinar, both the slides, the recording of the webinar, and a summary of the survey polling results will be posted on the VHHA website once we've had a chance to consolidate all this information. So certainly look for that information. And then in regards to our upcoming webinars, moving forward, we will continue to have the calls at noon on the fourth Thursday. Next month, we look forward to hearing from our colleagues at Augusta Health in Fishersville, their CEO, Mary Mannix, and their Chief Nursing Officer, Crystal Farmer. And then in August, we'll hear from our colleagues here in Richmond at the VCU Health System. And then finally in September, as some of you may know, the VHHA is underwriting a 5-hospital year-long collaborative with the Studer Group, and we'll hear from some of the folks involved in that effort as to what insights they've been able to gain working together on their patient experience improvement efforts. As Carrie and Nancy have both said, thank you all very much for all that you do each day to serve your communities and the patients and their families. Certainly reach out to us here at the VHHA if there's anything else that we can do. And one more time, many thanks to Nancy for not only her presentation this morning, but her leadership of the VHHA's Patient and Family Experience Forum. Happy supper to everyone. Nancy, any final comments?
No, just thanks everybody, and look forward to those future webinars. My good buddy Crystal Farmer will do a great job, and I'm looking forward to hearing her.
Excellent. Thanks everyone. Have a great day.
Thank you.
Thank you.